Thank you everyone for joining us. We're really excited to have everyone here. This is a very important subject to all of us at Science for Democracy, for our panelists, I think for most people in the audience as well. So we all know reproductive rights are under attack all over the world. So we've created this webinar to talk about how we can continue to access reproductive rights and how the right to science fits into that. Because here at Science for Democracy, the thing that we keep striving for is the right to science. So I want to thank our incredible speakers for joining us. We have a really, really amazing group, diverse experts, activists in a lot of different realms of reproductive rights. So we're really excited to have them. They will each speak their turn, and then at the end, we'll have questions. So for the people in the audience, if you have any questions, you can write them in the Q&A, and we will have them answered by our wonderful panelists at the end. If you can specify if you have a specific person you're directing your question towards, if you can write that in the Q&A as well. Otherwise, it'll be open for everyone. So on that note, I'm going to hand the floor over to our president, Laura Convertino, and she's going to talk a little bit more about the right to science and why we're here.
Thank you so much, Julia, and thank you so much, everyone, for joining us. I'm incredibly thrilled to have our panelists because they are absolutely brilliant. But yeah, as Julia said, I think this is a very topical moment to talk about female reproductive rights and abortion rights. The thing that I just want to focus on for a second, just to introduce and connect the dots for everyone, is how the right to science connects to reproductive rights and why it could be actually an interesting way to think about it, slightly different from what we usually might be doing. So the right to science, as many of you already know, it's a complex, multifaceted right. It encompasses the right for researchers to do free research, to access resources to do research, and to be independent in doing so. But it's also the right of people in the general public to take part into research, to access the results of research, and to have the possibility to develop their knowledge in science. Of course, if you think about more broadly, about the right to science and what that entails, you can immediately start seeing how the right to science is actually quite a lot to do with abortion rights and reproductive rights. As we know, it's quite, in many places in the world at the moment, also in the Western world, also in Europe, it's quite difficult for many women to be able to access knowledge about their bodies, about their rights, about how to access the system that can support those rights. Research on reproductive rights and female health is limited, is not well funded, it's quite biased in the way in which it's done. And it's becoming more and more difficult to invest and to study those topics, as we all know from what's happening all over the world, especially in this moment. So being able to make sure that scientists can keep on studying the field of reproductive rights on one hand, and on the other to improve the tools that we have to support women to make whatever choice they want to make about their bodies, and to have the highest quality of care when it comes to that, and to be able to access it. It's one side of the coin. There is also another important aspect, which is making sure that women have the knowledge about their rights, about their bodies, about how to make sure that whatever choice they make, they can access the support they need. It's incredibly important, and it's something that now more than ever, I think in the last few decades, needs to be really looked after, and we have to make sure we don't forget how easy it is for us to go backwards, how easy it is for us to forget, how difficult it might be for professionals, and I'm very glad that we have professionals here today with us to be able to do their job at the best of their abilities. And on the other hand, it's always important to have activists, policymakers, and human rights experts that keep on pushing for this right to be respected, that keep on pushing for women to be able to access what they need, and to make sure that they control and the choices over their bodies are only their own in the most free and independent way possible, because that's the only way to make sure that women are fully part of society, fully capable, and fully equipped to be well-rounded citizens of the world. This said, I think my little introduction is done. I don't want to take any more time from our brilliant panelists, which have met much more, I think, interesting things to say. And I leave the floor again to Julia that can introduce our panelists. Thank you again, everyone, for joining us.
Thank you, Laura. Yes, so we'll dive right in. Our first speaker is Melissa Cockroft. She joins us from Nairobi, Kenya today. We're very grateful to have her here. She's a sexual and reproductive health rights specialist. She has more than 16 years experience working in Africa and Asia, and she's currently the global lead on abortion at the International Planned Parenthood Federation. So I'll pass the floor on over to Melissa. Thank you so much.
Great, thanks, Julia. Yes, and thank you very much to Science for Democracy for the opportunity to be a part of today's panel. As Julia mentioned, my name is Melissa Cockroft. I'm the global lead for abortion at the International Planned Parenthood Federation, or otherwise known as IPPF. I think you can go to the second slide. So just briefly, a little bit of information on the International Planned Parenthood Federation for those who are perhaps less familiar with our work. So we are a global healthcare provider of sexual and reproductive health services with 150 local independent member associations and collaborating partners, with a presence in over 150 countries and growing across Asia, Europe, the Pacific, Africa, and Latin America, including the Planned Parenthood Federation of America, who is probably our most well-known member. Our member associations provide comprehensive sexuality education, contraception, safe abortion, and other integrated sexual and reproductive health and maternal care, including responding to humanitarian crises. To get a sense of the scale of our work, in 2023, IPPF provided over 220 million sexual and reproductive health services and contributed to 150 policy and legal changes supporting sexual and reproductive health rights. IPPF works to ensure that every woman, girl, and person who has the capacity to become pregnant has the human right to choose to be pregnant or not, and we continue to supply and support safe abortion services and care. Next slide. So what is the situation of abortion globally today? So just to give us some grounding for what we're going to discuss, induced abortion is in fact very common. It's estimated that 73 million induced abortions occur worldwide annually. But what's particularly troubling, I think, is that 45% of induced abortions are unsafe. And annually, it's estimated that 29,000 pregnant people, women, and girls die from unsafe abortion, and a further 7 million more are injured or disabled. Unsafe abortion also leads to social and financial burdens for the abortion seeker, communities, and health systems. More than half of all unsafe abortions occur in Asia, most of them in South and Central Asia. In Latin America and Africa, the majority, approximately 3 out of 4 of all abortions, are unsafe. In Africa, nearly half of all abortions occurred under the least safe circumstances. But perhaps what's most devastating, I think, is that deaths due to unsafe abortion are entirely preventable. It is lack of access to safe, timely, affordable, and respectable abortion care that leads to these preventable deaths. Next slide. So here, through these various images, many of which some of you might be familiar with, I've tried to capture some of the moments recently which represent the tumultuous time that we are seeing when it comes to abortion rights globally. And of course, many of these images are negative: the overturning of Roe v. Wade, the election of Donald Trump, and the reinstatement of the global gag rule, which almost seems insignificant in the wake of the dismantling of USAID. But there's also been some positives, such as the Green Wave movement in Latin America, the increasing availability of abortion with pills, France enshrining the right to abortion in its constitution, and just last week, a smaller but no less symbolic and defiant statement, the opening opposite the Polish parliament of an abortion center. So this is just a very brief snapshot through images of the state of abortion and sexual and reproductive health and rights globally. And as you will note, a lot of these images are from the US, and this is because, unfortunately, what is happening in the US domestically is having a significant influence and ramifications for abortion rights globally. Next slide, please. So I've included here this quote from the UN Secretary General, which he made at the opening of the recent 69th session of the Commission on the Status of Women in New York just a few weeks ago, which also marks the 30th anniversary of the Beijing Declaration. I'm including this as I think it accurately describes the global picture of what we are seeing in relation to the rollback of rights globally, and not just in relation to abortion rights, but human rights more broadly. So he says, women's rights are under siege. The poison of patriarchy is back, and it's back with a vengeance, slamming the brakes on action, tearing up progress, and mutating into new and dangerous forms. And around the world, hard-won gains are being thrown into reverse. Reproductive rights are under attack and equality initiatives discarded. Next slide. So, of course, we're witnessing attacks on abortion rights on a number of different fronts. So the US, as I mentioned, the reversal of Roe v. Wade and the election of Donald Trump as US president has emboldened anti-choice groups, not just in the US, but globally. These groups are well organized and coordinated. They're using the same language, tactics, and even funding channels across countries. Just one example, we're seeing significant and increasing funding flows from US Christian right organizations to Africa, with activities ranging from supporting like-minded politicians to obstruct key reproductive health legislation, to supporting domestic groups in their fight against progressive abortion-related court rulings. And these are all tactics borrowed from the anti-abortion playbook in the United States. We're also seeing a rise in populist or authoritarian regimes in places like Poland, Hungary, but also in parts of Africa and Asia, who have restricted access or made it harder to get abortions, often under the guise of nationalism, religion, or protecting so-called family values. We're also seeing the co-opting of women's rights and the proliferation of anti-gender rhetoric, with an emphasis on the role of family and motherhood as essential drivers for development. We're also seeing increased misinformation online and digital censorship of abortion websites, social media accounts, with content flagged or removed under vague kind of community guideline violations, with even governments banning websites. So, for example, the Women on Web website is blocked by the government in South Korea despite a legal appeal, which was unfortunately rejected. And then legal and policy restrictions, financial and geographical barriers, and stigma, particularly for marginalized groups like youth and adolescents, persons with disabilities, sex workers, gender diverse and trans people, prevents these people who want an abortion from accessing care. And this is even in places where it is legal. Abortions after the first trimester are also extremely difficult to access due to legal and policy restrictions and a lack of trained providers. Next slide. So that was the bad. On a more positive note, we are seeing countries moving towards expanding access to abortion in many regions. So as I mentioned earlier, the Green Wave movement in Latin America continues to inspire movements globally, so showing how feminist organizing can challenge conservative norms and religious influence. So we saw the Supreme Court in Mexico decriminalize abortion at the federal level in 2023, which was building on years of state-level victories. In Colombia, we saw abortion decriminalized up to 24 weeks, which is one of the most expansive rulings in Latin America. Thailand has also expanded access to abortion up to 20 weeks. France, as I mentioned earlier, has added abortion rights to its constitution. In Malta, where abortion was prohibited under any circumstance, one of the most restricted globally, has added one limited exception if the life of the pregnant woman is at risk, and with approval of a medical team of professionals under specific conditions. So you could argue that perhaps this isn't necessarily progress, because it's basically still very, very difficult to access abortion. And I know my colleague Isabel from Malta will speak more to this. In Africa, some countries like Benin and Sierra Leone have moved to broaden access under certain conditions, with a focus on maternal health and reducing unsafe abortions. In countries like the UK, Canada, and Australia, we see laws supporting buffer zones, preventing anti-choice protesters around abortion clinics to protect patients and staff from harassment and ensure access to services. And we see the continued expansion and availability of abortion with pills through national level policy changes, cross-border and online sales, and doula support networks. So even in countries where abortion is legally restricted, ensuring that even in some of the most challenging contexts, people can self-manage their abortions. And abortion right movements are more connected than ever before. And setbacks have sparked new waves of organizing, coalition building, and visibility, such as the My Voice, My Choice campaign, which Tina is going to share a bit more about as well. Next slide. So finally, I want to end with sharing some information on IPPF's Words to Win abortion campaign. So at IPPF, we recognize that the fight for reproductive rights isn't just happening in courts and legislatures and clinics. It's happening in the words we use every day, and particularly on social media. As I mentioned before, in relation to the increase in online censorship and misinformation that we're witnessing. Anti-rights opponents know that language shapes perceptions, and they have spent decades strategically shifting the narrative. Reframing is one of the most powerful tools that we think we have. So anti-choice movements have nefariously hijacked terms like life and choice, and we think that we need to reclaim them with accuracy and power. So when we talk about life, for example, we're talking about the lives of real living people, women and those who can become pregnant, who deserve the right to decide their futures. The ability to choose when or if to have children is fundamental to living a full and self-determined life. It's about economic stability, health, safety, and autonomy. People shouldn't have to be forced to carry a pregnancy to term. We also reject terms like preborn that strip pregnant people of their agency, and we must challenge the idea that life applies only to a pregnancy while ignoring the person carrying it. We must expose the deception behind anti-choice messaging and replace it with a bold, unapologetic commitment to reproductive justice. So that's why IPPF has launched the Words to Win campaign. And it's not just a campaign, we want it to be an ongoing conversation. So we know that language evolves, and so our messaging must evolve too. So we're inviting advocates, allies, and organizations to join us in shaping narratives that fight stigma, inspire action, and shift power. And if you'd like to know more about the campaign or take part in some upcoming events, please follow us on IPPF's social media accounts, or feel free to email me for more details. Words can shift power, so let us use them to win. And thank you very much. That brings me to the end of my presentation. I'm happy to take questions in the Q&A or at the end of the session, and you can see my emails there on screen if you'd like to get in touch.
Thank you so much, Melissa. That was very informative, very important. And yes, if people have questions, put them in the Q&A, and we will make sure they get answered at the end. So next, I want to invite Dr. Silvia Kalantari to speak. She's a clinical geneticist and researcher at the University of Pavia in Italy. She focuses on diagnosis and management of monogenic conditions. She's going to talk a bit about how prenatal diagnostics are affected by abortion and vice versa.
Thank you, Julia, for the introduction, and thank you to Science for Democracy for inviting me to this event. Now I'll try to share my screen and hope everything works as it did before. Okay. So, can you see my presentation now?
Yes, now we can see it, but it's still, the picture is small.
Okay,
Yeah,
oh,
perfect.
it is perfect. Thank you, Julia. So, I'm going to talk about something slightly different from my colleagues, a kind of subtype of abortion rights in a way. So first of all, I'm a clinical geneticist. I'm not working for any association, and the interest for this kind of topic came from a day-to-day activity. To be honest, like the first time I thought about the right to about how tricky it is the law regarding interruption of pregnancy for fetal malformations was during my 5th year of medical school, so many years ago, when a woman came into our clinic with a fetus with a severe heart malformation that unfortunately was discovered later on in the pregnancy, like 25 weeks of pregnancy. The severity of the malformation was so high that we weren't expecting the babies to survive at birth. But since the laws are how they are in Italy, and I'll talk about that later on, she couldn't have access to interruption and was forced to bring on this pregnancy. And it was back then that I realized how tricky this aspect can be. So I'm now working at the University of Pavia as a clinical geneticist. And the reason I'm talking to you about this topic is basically because of this viewpoint that was published in the European Journal of Human Genetics in July 2024. And it was a group effort. It wasn't just me. Actually, Mirella Paracchini did most of the work. She's from the Associazione Luca Coscioni too. And she was invited to a session that we organized during a European Society of Human Genetics conference back in 2023. So we focused on how variable these laws can be in Europe. So what I wanted to focus on is that there are some unique challenges that regard this kind of termination of pregnancy, because in this case, we're not talking about termination of pregnancy out of women's free will, just because they don't want that pregnancy, but we are talking about a pregnancy that was long waited for in many cases. So was a pregnancy that was wanted by the woman, but unfortunately, at a certain point during the pregnancy, an ultrasound examination in most cases revealed that there was some kind of fetal malformation. So it's an unexpected event. We are dealing with a woman that had no will to interrupt that pregnancy up to that point. Oftentimes we are dealing with a later pregnancy because, as I will show later, many malformations are only seen at 20 weeks of gestation or later. So we are not talking about the first 90 days of pregnancy, but we are talking about a bigger fetus and a later on pregnancy. And then in general, it's a more complex situation in which different health professionals are involved. Of course, the OBGYN, but also the clinical geneticist. Sometimes we also call neonatologists in order to assess how and if that fetus could survive birth, and also psychiatrists are involved, and I'll again talk about this later on. So this is a map that we draw in order to give an idea of how variable and how different laws regarding termination of pregnancy for fetal malformations are in the European Union. You only see here countries in the European Union. So all the other countries are in white in this map. And the darkest color is black. And you can see that Poland and Malta were the countries that in July 2024 were those with the more highly restricted laws regarding termination of pregnancy for fetal malformations. Because in these two countries, the law doesn't allow termination of pregnancy for a fetal condition, no matter how severe it is. As Melissa just mentioned, things are improving in Malta and somehow also in Poland, but still the law doesn't allow the interruption for this very reason. Then we have some countries, which are 14 countries where termination of pregnancy in this case is allowed up to 24 weeks of gestation. gestation. There are 11 countries in which termination of pregnancy for a fetal anomaly is allowed for whatever for the whole pregnancy, so without upper limits. And countries like Italy, my country, so it's basically Italy, Sweden, and Ireland, where the law allows for interruption of pregnancy for severe fetal anomalies up to fetal viability, which is not better defined in the law. And it can be tricky considering how much our technology to allow fetuses to survive even when they are in lower gestational ages are changing this. So to have a law that is not so well defined might be trickier and trickier as the technology improves. So in this next slide, you have all of the European Union countries with the gestational age limit, and then some specifications, because apart from the gestational age limit, it's important to note that also the laws are different regarding how they are formulated. So for example, sometimes the law includes terms such as serious or permanent, which are ill-defined terms that do not allow for an easy uniform application in different cases. So what happens is that there is, maybe like in France or Portugal, there is an ethical committee that is called to decide on each cases. In different hospitals there are different ethical committee, and similar cases might be decided upon in very different ways because the law is not so specific. It's utilizing terms that do not allow for a uniform application. So again, the importance of language, as Melissa already mentioned. So all of the information we included in our article was drawn from websites that are kept up to date with more recent laws and legislations. Here are the two main websites that we use for our report, for our article. The first one is Abort Report EU that you see here in this slide. It allows you to browse country by country in order to see the differences, and also allows you in the same screen to see the law in up to 3 countries at the same time in order to see the differences in more details. And what you'll see is that the laws are so amazingly different, despite the fact that these are all countries that belong to European Union. And this is the other website, which is from the World Health Organization, and includes information on countries from all over the world. Of course, we focused on European Union mainly because, like, the idea is that the European Union is very much like countries belonging to the European Union tends to have a similar ideological background. In fact, the European Union actually recognizes women's sexual and reproductive rights, and also abortion rights, but it affirms that member states have autonomy on this kind of legislation, so they are not forced to comply to a general idea. So they can be so different because of that. Also, in this slide, there is this article regarding how often there are abortions related to genetic abnormalities overall. This article was edited it was published in 2020, and the conclusion of the article is that still most abortions are for abnormalities which are suspected early in the pregnancy thanks to screenings. So most trisomies are detected very early on in the pregnancies. Still, despite the best of screening, what we have to keep in mind is that many organ and system are developing later on in the pregnancy. Like most most organs in system can be seen at 20 weeks of pregnancy, but it's also true that especially central system malformations are not apparent before the 3rd trimester. So even a malformation as severe as lissencephaly, so the lack of cerebral gyrations, so a condition which is related to a very, very severe outcome in the baby when the pregnancy comes to term, you cannot see it before the 3rd trimester. So no matter how good your screening is, you won't suspect this early on. So the kind of terminations related to this malformation can be terminations that are required very later on in the pregnancy. And as you have seen in the map that I showed before, many countries do not allow, in Europe, in the European Union, do not allow for termination before the 24th week of gestation, which means that even if I detect a severe cerebral malformation, after that week, you cannot interrupt. There is no way you can in those countries. Still, since those countries belong to the European Union, and the European Union allows for free circulations of people, those patients, those women that are rich enough or have the right cultural background will be able to travel in the neighboring country in order to obtain the termination of pregnancy that they desire. And the same, a woman with the same kind of severe fetal malformation won't be allowed to do so due to financial and cultural restrictions. And that's what seems to be the most absurd thing for professionals working in the field. Hence, like in 2023, we had the opportunity to discuss about this at the European Society of Human Genetics European Conference in Glasgow. Me and a clinical geneticist from Portugal, Raquel Silva, we belong to this committee of the European Society of Human Genetics, which is called the European Society of Human Genetics Young Committee. So it's a committee whose main aim is to defend young geneticists' rights and give us the opportunity to propose new topics within the context of this established conference. Is the most important one in genetics in Europe. And we asked to have this topic brought. And to be honest, it was a very nice session that was appreciated. Thanks to our wonderful speakers back then, who were Jose Ferreira and Mirella Paracchini. Raquel, so in this picture you can see on the left side, it's me, then Raquel, my colleague from Hospital de Santa Maria in Lisbon, and Jose Ferreira, who is a gynecologist there, and then Mirella Paracchini, who is a gynecologist herself and has worked her entire life for abortion rights. And she's now a member of the International Federation of Professional Abortion and Contraception Associates. So this was our little experience. We felt the urge as professional working in this specific field to raise awareness on this kind of very peculiar kind of abortion with completely different characteristics, but still happening in a time in women's life in which is particularly important to have the right support, because you wouldn't want to interrupt that pregnancy. Is fundamental that has, as professionals, do everything in our power to allow the smoothest possibility of choice as possible. So thank you for your attention. I'm happy to take questions later on when it will be allowed. Thank you.
Thank you so much, Silvia. Thank you so much. That was very informative. I think that's a part of the reproductive rights conversation that isn't talked about enough. So we're very grateful for that intervention. Next, we're going to hear from Dr. Isabel Stabile, the full professor at the University of Malta and an activist with Doctors for Choice. She's also the only openly pro-choice gynecologist in Malta. So it'd be very interesting to hear from her about the situation in Malta and how it is for her as a gynecologist. So Isabel, I pass it on to you.
Thank you. Thank you so much for the invitation. And here's my presentation that I hope I am able to share. Is it showing?
Yes, it's showing.
Okay, we'll get started. So thank you again for the invitation. I am really honored to have the opportunity of speaking in such a wonderful group of people. Thank you also to my previous speakers for alluding to the situation in Malta that I will obviously expand upon. So yes, I've titled this presentation, Abortion is a Fact of Life in Modern Malta, because in spite of what you've heard, which is that we have an almost blanket ban on abortion, in fact, we do have abortion. And it is almost all, I should say, entirely illegal. So let's see what it's all about. Yes, we do actually have one of the most restrictive abortion laws, and we criminalize women. And we also criminalize whoever assists. When I say women, of course, I do mean anyone who could get pregnant. And so we criminalize women for up to 3 years in jail if we find them guilty of having broken the law. And we criminalize doctors or anyone who helps them, including, so if you're a doctor, you're likely to go to jail for 4 years if they find that you've been responsible for causing an abortion. And worse, perhaps worse than that, you lose your medical license. So that means you won't be able to work again. So yes, it is one of the most restrictive laws in Europe, and certainly in the European Union. And thank you for that wonderful map that we saw earlier, putting things into perspective. And exactly as was specified, abortion is only allowed to save the life of the pregnant person, only if her life is at grave danger. So we also have to have a committee of 3 doctors meeting to decide whether, in fact, this is the case. There are absolutely no exceptions to this law. We now know that since this law was changed, by the way, it was called Bill 28, since it was changed in June last year, we've had 5 legal terminations. We don't actually know much more about them, but we do know that they did occur. So the law has been invoked a few times. So having said all of this, having said that we have very restrictive laws, I will tell you that we've received 590 packages of pills. Oops, and I'm sorry, that says 2023 there. That's a mistake, which I've just realized. It's 2024. The number the year before in 2023 was 490 something. So the number of pills being shipped to Malta, and this does not, I repeat, not include advanced provision. As you might know, Women on Web also allow the possibility of advanced provision. This does not include those numbers. We've had almost 600 packages of pills sent to Malta last year. And that is a 15% increase on the year before, which in turn was a 20% increase on the year before that, and so on and so forth. This is really the change that COVID has brought upon us. And so just as a little background here, I do represent Doctors for Choice, which was founded not too long ago, 2019. And yes, our main goal, of course, is to advocate for the decriminalization of abortion. But we also believe that we need to be preventing as many abortions as possible. And 2 of the main ways to do that, as we all know, is accessible contraception, which we do not have, certainly not free, and neither do we have comprehensive sexual education for all. So in a way, we're created a recipe for disaster. So being aware of this, about 4 or 5 years ago, the Family Planning Advisory Service was set up as a group activity between Doctors for Choice Malta and a couple of NGOs. And that has seen an incredible number of people reaching our call line, our helpline, for information. Information that ranges from, could I possibly be pregnant? My last period was, 5 weeks ago. Could I be pregnant? Questions like, should I take the morning after pill? Where can I buy the morning after pill? By the way, it is available without a prescription on the island. That was a hard-fought battle a few years ago. in spite of it being available, however, there are many pharmacists who refuse to dispense it because they are conscientious objectors. So this is a bit of a problem. 2 years ago, we set up the abortion doula service. And when I say we, I'm referring to myself and my colleague, Dr. Natalie Stabile, who together basically answer 1 to 2 calls every day from women who are either thinking of having an abortion, considering having an abortion, or going through the abortion there and then, or possibly after the abortion worried about symptoms, complications, what kind of follow-up they should receive, etc. So I just wanted to put that as a background. And on the slide on the right, I hope you can notice the immense drop in the number of women who would have traveled to other countries. The only country we have data from is England and Wales over the years. You can see that since COVID, right here, 2019, 2020, the numbers have dropped dramatically. And this is not simply because of travel restrictions, but also because of the availability of medical abortion pills. So that's by way of background. And oh yes, I forgot, I was meant to show you these numbers before. So here are the numbers of pills that were shipped to Malta in each year since COVID, basically. These numbers are much, much lower. You can see the introduction of medical abortion pills and how these numbers have literally galloply increased by leaps and bounds every year. So we've had almost 2,500 pills shipped to Malta in the last 7 or 8 years. Now, what are the risks of having an abortion in Malta? Well, there are many. And here, of course, I'm referring to the risks to women. There are risks to doctors, as I've already explained. But there are a number of risks, and you can divide them up into financial, emotional, legal, medical. As a doctor, of course, I will start with the medical ones, but they are probably the least relevant because, in fact, they're very uncommon. Bleeding and sepsis from retained products of conception are very uncommon in the case of medical abortions. Surgical abortions, as I've said, are only carried out legally on the island in state hospitals. We know 5 of them occurred in the last several months. So the medical risks of having an abortion in Malta are very, very small, in spite of the fact that it is illegal. The financial risks are significant. Yes, it's true medical abortion pills don't cost an arm and a leg, but for some people that is an arm and a leg. About 100 euros, 80 to 120 euros is not a small amount of money for some people. For those people who unfortunately need to travel, as the previous speaker has explained, to other countries for legal abortions, for fetal anomalies, which I remind you are completely illegal on the island, then we're talking 2,000 to 3,000 euros, possibly more, if you have to travel outside the European Union. And of course, this does not include things like sick leave days lost to travel, childcare, obviously follow-up visits to doctors, etc. So the financial burden is a significant one. I've mentioned already the legal burden, so I won't repeat myself, but there is, of course, a very, very significant emotional burden. And this is something that we're seeing more and more through our helpline. The burden of carrying out a medical procedure alone, and in many cases, these women are, in fact, having an abortion alone. They might have a partner, but they might not. They might have a family, but if they do, they would most likely not be sharing that information with their families. So they're literally having an abortion in a bathroom on their own while their mother and father are sleeping in the room somewhere else in the house. Or they might rent a hotel room so that they can be away for a weekend to have their abortions alone. Clearly, this leads to the concept of stigma and judgment that people have. We are a highly religious community, and you can imagine how all of this together can lead to mental health problems, of which we know very little, but I'm happy to tell you that we do have a very small number of pro-choice psychologists who can help us when we refer people to them. So I wanted to just also let you know how ignorant, I'm afraid, my colleagues are when I say my colleagues, I mean doctors like myself, are about abortion. And this is partly because, of course, none of this is taught in school, taught at university, taught at medical school. So we carried out a small study a few months ago to explore the knowledge and beliefs of medical doctors with regards to abortion. We circulated an online survey via email and looked at their responses on a number of standardized questions that were used in a previous survey some years ago so that we could compare them. Yes, as you might imagine with most surveys, about 60% of the doctors were female, the majority were Maltese, a quarter was single, 60% Catholic, the predominant religion on the island. About 65% had graduated in the last 5-10 years, and we specifically wanted to look at younger doctors. And about a third of them said that religion was important in their lives. So this is the characteristic of these people. And it was unfortunately a relatively small sample of people, of doctors in Malta, because many chose not to answer the questionnaire. Nevertheless, I will tell you that a whopping 57% actually believed that accessing abortion services abroad can be criminally prosecuted on the island. And that is untrue. It is something that we need to remind people about. The court of public opinion, of course, is one thing, but the actual court of laws will not prosecute someone who traveled to another country where abortion was legal. So this is important. It's important because it leads to doctors providing incorrect information to their patients. And here's another big problem. Almost 40% actually believe that providing information about abortion is illegal, which means that these doctors actually believe that my colleagues and I in Doctors for Choice are breaking the law, right? Because we are providing information. We provide all sorts of information that we believe that people need to know. We do this through our website, which, by the way, is quite often accessed by countries outside the European Union, especially Ukraine and the United States. But we do this also through our chat function that I mentioned earlier, and also through our doula service. So knowing that, realizing that information about abortion, providing such information is not illegal, is important for doctors to know. And of course, this is one of the most galling pieces of information. If 1/3 of our doctors actually believe that legalizing abortion will increase the number of women who seek abortion. And I don't have to tell the audience that this is absolutely untrue. So there's a lot of room for growth here. Now, we've also got a number of very strange personal beliefs. This is a good one. I mean, almost 3/4 think that women should not be punished for having an abortion. But this is good news. This means that we can rely on doctors to support any change in legislation. Unfortunately, I think this piece of information here is biased by the small sample size that we had, because in our experience talking to such doctors, in fact, they actually have a different view. You can see these numbers are very similar. About the same number think that doctors should not be penalized for helping them. And yet we know that doctors are the primary reporters of women who are having abortions. We've had a few cases in the last 12 months of women who were reported to the police for having had an abortion. And in most cases, those reports came from doctors themselves. One actually came from a social work professional, and a couple more came from partners. But unfortunately, because doctors seem to be misinformed, they do report women to the police. They also agree that a total abortion ban leads to unsafe abortion. Well, that's good to know. I'm sure you will. And they also mostly agree that it's possible to be personally opposed to abortion and still be pro-choice, which means they can actually help women should they choose to do so. And here is the big problem, of course, because we have approximately 1/4 of our doctors who believe that abortion is taking a life, because life begins at conception. And this is the big barrier that interferes with everything that comes after it. So the main conclusions here is that although in this particular study, relatively small study, the majority of doctors who responded agreed that abortion should be decriminalized, yet most are severely lacking in their knowledge. And so we really need to work on these two issues if we want to make a difference. Now, I also want to show you this small piece of information. I'm sorry, the letters are very small here, but I will read them out to you and I'll explain what we're talking about here. So the same number of doctors, and we asked them, would you agree with terminating a pregnancy under these conditions? And this is strongly agree. This is yes, need to register a reason. Yes, strongly agree in blue. Agree, neither agree nor disagree, and this is disagree and strongly disagree. Okay, so you can see that the only place where the majority of doctors, the only two places where the majority of doctors agreed or strongly agreed that a termination of pregnancy should be allowed are either in the case of a non-viable anomaly, such as an anencephaly, or if a woman's life is in danger. Okay, now with this part, as we've said before, has already been dealt with. Of course, it only affects a relatively small number of women. The Andrea Prudente case was, of course, what triggered this a couple of years ago. The case of fetal anomalies, although most doctors do agree that it should happen, should have a termination, it is still illegal. The next most common one is to preserve a woman's physical health, such as serious heart disease or cancer. Our doctors obviously do not agree that viable fetal anomalies should be allowed a termination. They certainly do not agree that it should be allowed for no reason at all or for social reasons. So we have a very conservative medical society. So I'm going to stop here, and as your colleagues said, take questions in the QA later. Thank you.
Thank you, Isabel. That was, yes, a very needed reminder as to how restrictive it is in many countries and how this affects our physicians. So thank you for that. Next, we'll hear from Tina Tomšić, who's one of the organizers for the European Citizens Initiative, My Voice, My Choice, which Melissa also mentioned, and Tina will discuss as well. It's I believe the fastest European Citizens Initiative to reach 1 million votes, which they did quite recently, so that's very exciting. And I'll pass it over to Tina to talk some more about it.
Hey, so I would like to thank to all of previous presentations, because I think they outlined the situation with abortion access really well. I come from Slovenia, from an organization called Institute 8 of March, and in Slovenia we have abortion written in the constitution. It's something that we're very proud of. So it's a country that has a long tradition of reproductive rights that are managed quite well. There's no problem with access. But at the same time, our organization also started the My Voice, My Choice campaign for accessible abortion in Europe. And this happened in a way that when the director of our organization studied in the USA, she was there when Roe v. Wade was overturned. And it was a moment in which many women, people who can get pregnant, lost their constitutional right overnight. And she could see the desperation that this situation brought to everyone around her. And she thought to herself that we need to do something on the EU level or in Europe in general when it comes to protecting reproductive rights, because even though a lot of countries have a well-managed access to reproductive rights, to abortion rights, such as Slovenia, there's always a possibility of a change in government, of a change in laws that we take for granted. And we started to think how we can do like a campaign that would be on the European level. And the thing is that like we had no idea how to do it. We had experience with campaigning in Slovenia. We've changed about 15 different laws in Slovenia. We won 2 referendums. But when it came to pan-European movement building, we were lost. And until we found the mechanism which is called European Citizens Initiative, which is like a mechanism of direct democracy where you can propose a specific change to legislation on EU level if you collect 1 million signatures and if you collect enough signature thresholds in 7 member countries. So almost, yeah, so about 2 years ago, we started working on this campaign. In autumn 2023, we gathered an international team of lawyers, and we started thinking very hard on how this, what can we do legally speaking when it comes to suggesting a change in legislation to the EU when it comes to abortion rights. Because it's quite tricky, as the European Commission doesn't have the competences when it comes to healthcare. So it's not, there's not much possibility to do when it comes to reproductive rights or abortion rights. And the way that we did it was that we proposed a change or an addition which would grant financial access to anyone who has to travel in order to get an abortion. So our suggestion was to create a financial fund that would then cover the cost of abortion care in another country for anyone traveling in order to get an abortion, or even in countries where abortion is not included in the general insurance and therefore is not financially accessible even for citizens or for anyone who's not insured and lives in an EU member country. So the idea was to grant financial access, especially because anyone who has to travel in order to get an abortion has to pay up to 5,000 euros in order to get one. And because Slovenia has such a well-managed access, there's a lot of women from Croatia, for instance, or Italy coming to Slovenia because they can't access abortion in their country due to conscious objections. So they travel to Slovenia, and even in Slovenia, they pay a couple of thousands of euros to get the procedure. So this was the idea. And then we started with our campaign. We had to create a big coalition, and the idea was that we get at first maybe 7, which is the number of needed thresholds, or 9 thresholds just to be on the safe side. But what we did in the end was that we currently have over 1,200,000 signatures, and that we have 19 national signature thresholds. And the way that we did it was that we were just very honest and open with anyone that we approached. More than a year ago, in January, we started contacting a lot of different organizations from all parts of civil society, so not only feminist organizations or organizations focused on reproductive rights. And in the end, we now have around 300 organizations which are part of our network. We blindly believe that we can do this campaign only with the help of organizations and by activating civil society in such sense, but we quickly realized that we need other parts of activation. We managed to connect over 2,000 volunteers and are organizing also on the ground. So we had groups collecting signatures in different cities in Italy, in Belgium, in Germany, in France, Spain, Austria, in basically almost all EU member states. And what we did was we created a huge movement which fights for abortion access. And together with all of our contacts, and the people that stand behind the movement, we managed to collect the 1 million signatures in December. I'm not sure if we are the fastest growing. I know that we are the fastest growing to get 500,000, because we got 500,000 in about a month, a bit more. But the thing is that then we started collecting last April, And then summer came and a lot of people are gone for vacation and everything stops a bit. So it was very hard to restart the campaign, but we managed to restart it and get to the million by December. So our campaign is currently, we finished the signature collection. We will close it officially on April 17th. But we still have so much work to do with actually getting this proposal passed in the European Commission and then later in the Parliament. So we believe that we will continue with our campaign for at least 1 more year. But the most important thing is the community that we created, the people that stand behind it, the international support that we've gained. Daily we get messages from the USA, of course, from women who find hope in this movement because they believe that they need something similar in the States and want to be part of this. We get messages from women from India, from Australia, from Canada. So basically on our social media, we created a global movement. And it's just wonderful to see how many people can see hope when it comes to reproductive rights and what can we do when we unite. So I will stop here and expect any questions.
Thank you so much, Tina. Yes, seeing how the growth of the campaign has been incredible, and I agree. I think it's a great source of inspiration for activists and organizers all over the world. So we're grateful to you and the whole My Voice, My Choice team. And we want to make sure that people keep supporting you and keep signing, keep supporting you after the signatures have been submitted. So we'll also keep posting about that on our website for everyone in the audience who wants to know what's going on. You can also always, of course, follow My Voice, My Choice on all their social media and on the website. Note it'll all be updated. So thank you again, Tina. Okay, I'll start with the questions. Okay, so we have one from Mirella. My Voice, My Choice is a great example of how citizens can influence institutions. How can My Voice, My Choice initiatives continue?
Yeah, so basically, as I said, our campaign is not finished. We will have at least a year more for campaigning because although we collected the signatures, we need to bring them all into the European Commission, wait for the decision from commissionaries, then wait for the hearing in the European Parliament. So the campaign will continue in a bit of a different way, and we won't stop campaigning. It will just change direction from the signature collection to a more pressure focused campaign. But basically, right now, we are not thinking of any other, like launching any other initiatives or going in other waters because we want to conclude this one. It's still a lot of work going on behind like the scenes. We still need to get all of the signatures that were submitted by paper in one place. So it's a huge procedure because in every country, all of the signatures need to be first verified, which will take about 3 months, and then it's going to the institutions. So we're glad if anyone joins us. We have a beautiful community on WhatsApp as well, where we update each other, where we do also online campaigning or in-person campaigning, and we'll need anyone who wants to join.
Thank you, Tina. I have a kind of a quick follow-up to that, or not quick, I'm not sure. But do you have any advice for, activists in other parts of the world, maybe in the US or in other places, other regions, who might want to start something similar in their sector, in their part of the world?
I think it's important to speak about common values when we are working with campaigning, when it comes to reproductive rights, when it comes to any other topic as well. Because, for instance, when it comes to abortion rights, as also Isabel managed to show, is that the majority does believe that it's a right that people should have access to, even though they don't personally agree with abortion, or if they are religious and don't believe in abortion because of those kind of reasons. The majority still believes that women shouldn't be prosecuted if they have an abortion. And this like we see abortion as a common right and as something that the majority of Europeans, but I believe that polling could show that even across the globe, do believe abortion access is something the majority believes in. So it's just a matter of how inclusive you are in your fight and how much you open it up. We have a lot of men also fighting for this cause in our community, also religious people. So it's just a matter of acceptance of anyone who wants to help.
Great, thank you. A question for Dr. Stabile. Do you feel that doctors who tell on their patients or on the people who have had abortions, would you view that as a violation of either the Hippocratic Oath or of their role as a doctor, as a physician?
Oh, yes, of course. I mean, what's happened to confidentiality? I mean, so I'm sure there are laws that are different in different countries. The situation in Malta is that doctors are allowed to break confidentiality in the case of minors when they are a risk to themselves or to others, which makes a lot of sense. Of course, you need to protect people. But when it comes to extending this, so there's this misunderstanding. I think there's this misunderstanding among doctors, again, partly because of our educational system that doesn't explain these things. Doctors seem to think that maybe the right that if they're reporting because they feel that this woman is putting the life of another at risk, and the other is the unborn or preborn or whatever, if they're preborn, then I'm pre-dead, right? This kind of thing. So yes, it's all to do with poor education, poor information among doctors. It's a terrible thing. It is terrible. And once this case is over, we have a case going through the courts right now. Once the case is over, and I sincerely hope that she will win her case, I will be speaking with this doctor. I know exactly who he is. In fact, I've already spoken to him. That was a few years ago. But I will be speaking to him, and I might actually make a report to the medical council. Right now, I can't because it's not public knowledge who he is. But there will be consequences, for sure. Great.
That's incredible. Thank you for continuing to do that fight in every capacity. That's great. Could you speak a little bit more to how the Malta's abortion ban impacts your ability as a gynecologist to do your job?
Yes, well, as you can see, it does and it doesn't, because I do provide all the information that is needed. The difficulty arises, as one of my colleagues, as Silvia said earlier, with people who have fatal fetal anomalies. Here we're really, really stuck, because the only thing we can do is to find a home, an external home, and that map, Silvia, by the way, was very helpful. Thank you for that. Another place where they can travel, preferably within the European Union. But again, we're limited by gestational age. And as you heard, unfortunately, sometimes these diagnoses are made very late, or quite late. Or in the case, we've had a case recently, I won't mention the gestational age, but the problem was the woman herself, the girl, actually, she was a very young girl, didn't realize she was pregnant until very late. So here we have difficulties of travel time, cost, of course, but just providing information. We rely a great deal on the Abortion Support Network, and they can be helpful. Sometimes they're less, they have less information than we wish they did have, but they do certainly help us to find a home for these women. So yes, it does. In a way, it does impact my role. I still take it very personally and very seriously. We need to help these young women because most of them are young, right? Most of them are under the age of 25 or 30. Nevertheless, there are people outside the, shall we say, the pro-choice movement who feel that this, our involvement as Doctors for Choice is breaking the law, that we're actually pushing the limits. We're not. We're just providing information. And of course, coordinating as much as we reasonably can without becoming actually, the holder of the hand that makes the abortion happen, because that, of course, is against the law.
Great. Thank you so much. We have some more questions, and to the audience, we still have some more time, so ask your questions and we'll try to get to everything that we can.
I might actually have a question myself, because I want to take advantage of the situation and having all of you here, all the panelists, to ask something. So we have Silvia and Isabel that are medical professionals, and they really see on the field what's happening. I feel my own frustration at times, although I'm not a gynecologist or a geneticist, is that it is difficult, at least might be my own personal experience, to connect the dots between doctors and activists and policymakers. And it's quite difficult to communicate with different languages, with the word of science, but also to try to translate that into real change in policymaking. On the other hand, we have Tina and Melissa that are more working hands-on on that side of things. I wonder, really a question open to all of you, but what's the key there? What do you think might need to happen? What's actually going to be useful to connect these two words and to push forward for new change? Because, for instance, Silvia, I think, gave a very good example for something that is very much needed, and Isabel as well, in terms of public knowledge, but also action and policy making. And yeah, I would really like to hear your feelings about it, and whether maybe my difficulty in connecting the two words is very much personal and you didn't have the same experience, but if you have any feeling for that, it would be great to hear.
I can just say that my personal experience was the one related to the European Society of Human Genetic Conference. I felt that back then, when we managed to have that session on termination of pregnancy, it was already a win, because we managed to ask to a scientific society to deal with an issue was mostly political or ethical. I mean, they do deal with ethical issues in genetics normally, but this was something different, and we were so grateful that we managed to convince them to bring up this session. And also, like, there were so many geneticists in that case, of course, because it was our annual conference, that came to us at the end of the session telling us that this was so much needed, that it was difficult to address this issue, because of course I'm talking about my profession, but I'm sure it's even more like so with the gynecologist. But like, for clinical geneticists, we are there when these kind of malformations are found, and we always have to deal with the, first of all, the emotional stress of the woman. And apart from that, like, I can talk for Italy, because again, I'm not a lawmaker, or I'm not working for an association, and just can talk about my day-to-day experience. What we have when we have to communicate about the malformations and possibility of diagnosis, we also have to tell women when it's we detect the malformation after at the 20th week of the gestation. Like, the Italian law, yes, it allows to interrupt pregnancy, but in theory, that interruption of pregnancy can only be done because of severe maternal issues, which is different from doing it just because there is a malformation. The woman has to speak with a psychiatrist. So in that context, I not only have to deal with the emotional issue of communicating the diagnosis, but also to tell the woman that she has to talk with a psychiatrist in order to get to what, in many cases, those women are expecting to be the right, just because there is a severe issue with the pregnancy. So this is something I noticed in my daily life, and realized that on the other side, we have the lawmakers that have no clue of how difficult this can be, because they don't like this kind of technology that allows us to do this kind of a complex diagnosis are new. Of course, ultrasound has been there for several decades now, but like, the kind of genetic diagnosis that I can do, they weren't there 10 years ago. So of course, policymakers have no idea. And I think that in this context, actually, the kind of experience Tina's explained, that's the kind of thing that will allow us to get to policymakers. If we manage to get 1 million signatures by advocating for reproductive rights and educating about reproductive rights in the general population. What I've noticed in my, of course, I'm speaking about termination of pregnancy for fetal anomalies, which is my experience. What I've realized talking with the general population, they have no clue about how difficult it can be, because everybody, I mean, not everybody, but mostly in the general population, we know about abortion rights. They don't know about how tricky it can be to have that right for a specific, in this specific context, when the termination of pregnancy is not wanted from the beginning. So I think the key is educating and advocating through associations like Tina's.
Yes, I completely agree, of course. If I just add one more thing, laws are changed by politicians. We democratically elect our politicians, and then they, unfortunately, or fortunately, depending on who they are, represent us, right? And so here's the problem. The problem is, at least in Malta, that privately, if you speak to some of these politicians, they will tell you that they're pro-choice. They will act upon that in the sense that if their, wife or sister or aunt or friend needs an abortion, believe me, they will call us and they will get what they need. But then you put them in a House of Parliament, you put them in a debate, you tell them to openly speak up, they won't. They're afraid because all they care about is votes. So in terms of how do we change this? Well, we need to somehow convince them to speak up about their personal views. We had one MEP, Maltese MEP, who did that in the last election cycle. He did not go out for election again because, he would not have been elected. And he only came out and said that after he had been elected. So it's this two-edged sword.
And maybe just to add as well, I mean, the approach that our member associations take, and, they're working in very, very different legal, context, depending on where the country the member association is based. And so the approach we tend to take is it's multifaceted. So it's because we're mostly a service delivery organization. We work very closely with ministries of health and policymakers, and we try to tap into relevant reproductive health coalitions and networks, which bring together other similar civil society organizations and NGOs, other healthcare providers, but as activists. And then we also do a lot of training with media and journalists, and even with Ministry of Health, decision makers and policy makers as well. And one of the approaches we take is the values clarification and action transformation approach. So it's a facilitated approach which takes people through, a range of different scenarios to try and, I guess, help them to understand and reflect on, not necessarily to change their values, but to reflect on their values, but also present different scenarios that, women and people who can get pregnant in the community face, or the challenges they face in trying to access abortion. So the approach, I guess, it happens at different levels. It happens at the policymaking level, but also the community level as well. So it's making sure that people have access to information, because even in contexts where abortion might be legal or legal under certain circumstances, often the community, they don't know. Because of stigma, because of cultural taboos, which makes it very difficult to access the information or even talk about the information. So it's a very sort of different approach that takes different sort of levels of who you talk to and that kind of thing.
Thank you. Yes, thank you. All of you, those were great answers. And we have another question here for Isabel, but I think also for anyone on our panel. I think you all have such outspoken stances on abortion. Have you received threats or harassment because of that?
Well, yes, of course. Although I will say, interestingly, the number of hate speech and hate mail that we've received has decreased over the last several years. And this is rather strange. I mean, it started off as being absolutely terrible. I mean, we were told to go, we would be shot, that we'd be decapitated or whatever, terrible, terrible things. And what we did with each and every one of those hate speeches was report them to the police. We reported every single one. And we have no idea what happened with those reports because we know what the police are like. But we reported every single one. And now, interestingly, it's much less. I mean, the comments under any article that any one of us might be quoted in, the comments are to die for. They're so funny, where they literally tear us to pieces. But it's not hate speech. It's like, oh, baby killer or whatever, shredder of babies or stuff like that. It's quite funny actually. But in terms of actual impact on our practice, well, my colleague and I are fortunately independent practitioners, so we're not employed by an organization, a medical organization. So basically, we don't have a boss that can fire us. I am, of course, also a full-time professor at the University of Malta, and yes, it has impacted my progression there to some extent. We managed to overcome the barriers because obviously you need to have friends in high places. But yes, there were attempts at trying to close my mouth and make me not speak up, but it doesn't work. So just keep going.
Yes, I agree. I myself used to work for Planned Parenthood in the United States, managing one of their phone lines. And yeah, the things you hear. So I completely understand. And maybe also for Melissa, I'm not sure. I know at a lot of the Planned Parenthood centers in the US, they need to have heightened security. I mean, they've already have very dangerous incidents happen there, but is it the same for you in Nairobi and the other places you've worked?
Yeah, so I think some of the different, I guess, forms of threats and harassment we see are these mystery or fake clients. So coming to the facilities, pretending to need abortion care, to try and sort of catch out the providers who are providing care, within the framework of the law, or disgruntled, partners who perhaps they haven't been consulted that their wife, is seeking a termination of pregnancy. I mean, in some very extreme cases, we have had providers like arrested. There was one very extreme case. Actually, it was a partner organization we're working with in South Sudan, where actually both the woman, actually, no, this wasn't even for abortion. This was just for family planning and contraception. She was prosecuted and put in jail along with a provider for, I think it was just getting a contraceptive implant by her husband. So, I mean, that's obviously an extreme example, and it's not even, directly related to abortion care, but, these are the kinds of challenges we're seeing, or threats even just to reproductive health providers as well. But yes, the mystery clients or the fake clients are obviously there. And, the US is, as you said, it's just a whole other, it's a much, much, much bigger scenario there.
Yeah, exactly. Thank you, Melissa. So I think, unless there are any other questions, I think maybe Mirella in the audience, I know has worked with Silvia before, so I don't know if she has something she wants to add. Yes, Mirella, let me make sure you can speak. Okay.
Thank you very much. Thank you very much. It's only to say that I wanted to thank you, to thank especially Isabel Stabile from Malta. She's doing a great work. And I would like to say that maybe the most difficult thing is to put together all the people involved in this struggle for sexual reproductive health. This is the great goal that My Voice, My Choice campaign has reached. They could really put together a lot of things and a lot of movement and association. And I think that humans has to pursue it, this kind of initiative and mode to deal with the issues. So let's go on. Thank you to you all, but really keep in mind that we have to put together so many differentiated movement, because if everyone does it, I'm thinking about IPPF as well, and I thank, of course, Melissa. But this is the real question: to put people together, to put doctors together, to put movement together, citizens together. In Europe, it should be maybe easier, and so in some way, this is an appeal that I'm doing for the chance that I get to, that I have to talk with all of you. Thank you.
Thank you, Mirella. And then on that wonderful call to action, I think we can close this out. I want to thank our incredible speakers once again. I want to thank everyone who attended. The webinar will be recorded, so if you want to share it with anyone, it'll be up on our YouTube channel in the next couple of days. If you have any other questions for any of our speakers, for our organization, for our partner organizations, Humans that Mirella just mentioned, and Associazione Luca Coscioni, you can send us an email. It's info@sciencefordemocracy.org. I've just put it in the chat as well. And once again, thank you to everyone. As we've said, we need to all keep fighting together, as Mirella has said. So yeah, we'll stay informed, we'll stay united, and together we can keep promoting reproductive rights and the right to science. So thank you everyone very much.